This is Dr. Chahla from Midwest Orthopedics at Rush in Chicago, Illinois, and today we will be presenting a case of a lateral meniscus radial tear that we solved with a hybrid technique utilizing the first pass mini to be able to reduce the extrusion of a meniscus, adding 3 all-inside sutures using the fast fix flex. This allows for increased reliability of the repair. It allows for a more anterior repair because we can bend the devices and reach more anterior zones of the meniscus and be able to recapitulate the anatomy and the biomechanics of the meniscus. This meniscus repair technique can be utilized both in the medial or the lateral meniscus. On the medial side, we can reduce extrusion as the medial meniscus has less mobility than the lateral one. When we do this on the lateral meniscus, we need to make sure that we allow for some motion of a meniscus as it would be on a normal meniscus. This can be done from a posterior horn all the way down to the body. And now with this new fast fix flex devices, we are able to reach areas that we were not able to reach with previous devices. After probing and identifying the tear pattern, the first thing that we do is we prepare the bony bed to make it a good healing environment. For this, we utilize the ring curette that comes into the system, and we basically remove some of the cartilage underlying the tear. We then use the root repair set to place a guide that will basically position a cannula at the bottom of the radial tear. As you can see here, it's important to have that flush with the cartilage so that the sutures don't get cut. We next insert a sport port cannula to allow for good suture management and avoid suture tangling, and this can be tailored to the patient size. The first pass mini is inserted and we pass a suture from bottom to top. This is a mini suture tape that will be passed on the posterior leaf, and then we do the opposite, passing a suture from top to bottom on the anterior leaf. It is important here that when we are passing the first pass mini through the cannula, that we pull on the other suture as we push, and this will avoid significant suture tangling during this procedure. We then fit the monofilament through the transtibial tunnel that was previously made, and the sutures are brought back from the cannula that we had previously inserted through the transtibial tunnel. In order to do this very easily, it's important to pinch the sutures on the monofilament and then pull very slowly and ensuring that there's no suture tangling while we do this process. As you can see here, we should be able to see both limbs of the suture at the bottom of the transtibial cannula. We then start our all-inside device repair. We put a sled cannula first to make sure that we don't have any issues with the cartilage going in with the device. As we were not able to reach the zones on the anterior portion of the meniscus, we are now able to bend the fast fix flex that will allow us to get anywhere that we want on the body of the meniscus. We insert this on the posterior portion of the tear. We want to know that this has been deployed into the capsule. We retrieve this slowly, making sure that we still have the device in view, and then we go to the most anterior portion of the tear. We don't want to be too close to the tear because there could be some cheese cutting effect, and therefore we want to be at least 4 or 5 millimeters anterior to where the tear is. We can then utilize the NovoCut device. One is using it as a knot pusher, so we can decrease the chances of the PICC implants coming or cutting through the tissue, and also to cut the sutures once the appropriate tension has been set up. As you can see here, we are in the white zone, and we are trying to get this tension right to make sure that the meniscus tissue doesn't overlap, but also there are no gaps in the tear. Multiple sutures can be added until the configuration and the construct is solid and is secure. We're going to add another suture in the white area. This should only be done in patients that have a traumatic tear that have really good tissue quality, because if there's any fraying of this portion of a meniscus, it should probably be partially meniscectomized. As you can see in this case, the tissue quality is optimal in this patient, and therefore we proceeded to add additional sutures to secure the whole meniscus and avoid resecting any portions of the meniscus. Finally, this has to be retensioned again, as well as cutted to be able to have no knots on the meniscal surface. For the tibial fixation, we have two options. One is we can use a cortical button to tie the sutures onto the anteromedial tibia. We like to do this in 90 degrees of flexion to ensure that those patients will be able to have immediate range of motion from 0 to 90 on postoperative day 1. We tie this over direct visualization to make sure that the appropriate tension has been set. Alternatively, we can use a footprint anchor that will allow us to tension the sutures after the anchor is seated into the hole. This can be done under direct visualization as well. And while we have the camera in the joint, we can toggle on each of those sutures until the appropriate tension has been set. And after that has been done, we can lock the sutures into the eyelet, securing the repair. The rehab protocol depends largely on the concomitant pathology, but patients remain non-weight bearing for 6 weeks. And then over the next 2 weeks, they will advance to partial weight bearing to full weight bearing as tolerated. Patients will start physical therapy on day 1, working on range of motion from 0 to 90 degrees, and progresses a strengthening program that will finish with an endurance and agility exercises within 4 to 6 months. Running progression can start at 4 months, and return to sports is allowed at 6 to 9 months, depending on the concomitant pathology.